I think the next session is we will jump right into the MAS trial session, and we'll start that with the patients. And I think the way we want to do this is that I actually have a slideshow, but we're just going to, I don't even know how to play in Google Slides. We'll just use that to tell the patient stories more easily. So Regina, Sarah, and Robyn, can you highlight them? Yeah, I think we were planning to start with Robyn. Robyn, can we? And the idea is simply that we have, I think I need to share my screen. Let me do that. Sorry, I'm just getting situated with this new way of doing patient stories. So we'll have Robyn's story here in the background so that you can, let me just, yeah. So Robyn, do you want to just, so your child, it sounds like, has had one major MAS episode, yeah?
Yes.
And if I may ask, where were you at this? Like, how did it start? Can you just talk about that a little bit?
Yes, it started, I would say, when she was about 10 months old. We noticed that she started having rashes that would not go away. And we took her to, the pediatrician, and she was diagnosed with eczema. We did allergy testing. They based her rash off of, just a lot of allergic reactions to different things. And when she turned 1 year old is when we noticed that she started to run the high fevers between 103 to 105. And I took her to 5 different doctors who kept dismissing it as viral. And I found one pediatrician who decided to order lab work. And that's when we realized how sick she was, and she was immediately hospitalized. But of course, at the time, we didn't even know what it was. It took 12 days into the hospital for us to get a diagnosis. That's when they said it was secondary HLH. They didn't think it was SGIA at all. But of course, she was declining very rapidly in the hospital with no answers for 12 days.
Okay, and they gave her the HLH protocol, and that didn't work. And I just want to, were you at your local hospital at the time?
Yes, we were.
Okay, and they were, and then where, and I think later on they discovered that it was actually not HLH, it was actually, how did that happen?
Well, she did the 2004 protocol, but as we got further into the treatment, when you start to chemo on 1 week and the steroids on the other, when she was not on steroids, the rashes started to come back, a lot of joint swelling, she wasn't walking. So at that point, her hematologist, where she was getting her treatment, decided to do an ANA blood work panel on her, and it came back positive for antibodies. And she reached out. We only have one pediatric rheumatologist in our city here in San Antonio, Texas. So she reached out to him, and within 24 hours, we were seen by him, and we confirmed the diagnosis of SGIA.
Got it. And even now, do her labs kind of show like the signs of MAS at points, or is it mostly SGIA now?
It's mostly SGIA. We've only had one other scary episode. They did not say it was MAS, but I kind of feel that it was because a lot of her counts dropped very low. Her white blood count dropped very low. The rash was really like it was taking over her whole body on her last hospitalization, and also her soluble IL-2 also went up at that time, that they do use for the MAS marks.
Got it. Okay. We'll move on to Sarah now, and please guys stay around because during the discussion too, we hope to be able to come back to you guys. Sarah.
Hi.
Hi. So you've had a, kind of an eventful 2 years, correct?
Yes.
Yeah. So once again, I think your diagnosis was initially HLH too, correct?
Yeah, it was initially HLH. Avery also went through the 2004 protocol of etoposide and dexamethasone. And what she was improving, not dramatically, but slowly. And then as soon as the dexamethasone started to wean off, then she started to flare again. And it was apparent pretty quickly that there was something else going on.
Got it. And that's when you were medvac to Cincinnati, yeah?
Yes, we were being treated in at All Children's Hospital in St. Pete, Florida, and we were medvaced to Cincinnati. And at first, it was a conversation of whether or not she needed a bone marrow transplant, because again, it was the discussion of HLH. So we were in that unit for 30 days, and then we were moved to Dr. Grom's care, and he treated her with Gamifant.
And this was, you were not in the clinical trial, yeah? This was out of the clinical
Correct.
trial.
Out of the clinical trial.
Yeah, and then you went back, and then again she got sick, yeah?
Yep, we were being seen in Florida by our local rheumatologist, and then we were flying back to Cincinnati every couple of months to be seen. And during one of the off months that we were in the hospital, Avery again started to flare.
Okay, and what did you do this time?
That again, it was like the weekend. I think it was a Friday, and then Monday was a holiday. So instead of waiting for medvac, which would take 6 days or so, we decided to discharge her on our own against medical advice and flew her to Cincinnati. And all of this, like the flying is usually it's not an issue for most kids. I mean, Avery loves to fly, but it's how much care she needs above that, like how many stops in between, and then keeping her away from other people. That was the hard part, especially during COVID.
Got it. Yeah. So you've flown her to basically to safety, and recently you decided to move for that reason. Yeah.
Yep. There was the last flare that she had. We were in Cincinnati in July, and then it was like the end of July. She was hospitalized for an endocrinology issue. Again, that was after weaning from steroids. And then in August, so just a couple of weeks later, she started to flare. And that was when we had to take her out of the hospital against the doctor's advice. And we flew her here, and we haven't been back to Florida since. So we actually sold our house and are now residents of Ohio.
So it sounds like when she gets sick, then it's not like, it doesn't take much time for her to go from okay to in the middle of MAS. Yeah.
Right. Like the last episode that we had, she was actually just discharged from Cincinnati Children's. We were staying at a hotel nearby until we could get some other living arrangements situated. And the hotel is like maybe a mile away from the hospital. And Avery had missed 1 dose of steroids and 1 dose of Kineret. And that was just by nature of getting the medicine. And she went into a flare really quickly. And it seems like every time that she starts to flare up, whether it be the SJA or the MAS, it's happening, like she deteriorates quicker. And that last time we actually ended up in the ICU for 3 days. We almost lost her a couple of times. It was, if we were in Florida and this were to have happened, I wouldn't have been able to get her to the hospital fast enough.
Got it.
So that was another decision that we made to stay here instead of go back.
And her disease is a mix of SJIA and MAS, correct? And
correct.
If done, let's imagine, I think there's some, we're discussing clinical trials here, and you haven't been in one, but I think we are a parent who has dealt with what MAS can be like. Suppose for a trial, you had to, and you did go without her drug because of insurance reasons one day, and next day she was in the ICU.
Correct.
So suppose for, clinical trial reasons, you had to stop some of the biologic medications that control her SJIA. What do you think would happen to her?
I would not enroll her in that study if that were to be the case, unless she was hospitalized and Dr. Grom took a bed next door or something. Like that's the only way that I would feel comfortable with Avery being involved in that. It's so clear that the MAS flares so quickly, and it can make the kids so sick that it's almost, I'm not going to say it's not worth it, because obviously it would be, but it's not worth it for us to try to risk that.
Got it. Okay. We'll come back to you when we're discussing the trial itself, and then Regina, who's actually known to this community, and we have a little bit of, hey Regina. So just, kind of, for those who've been to the conference, you've heard her story, but it is a pretty dramatic story, somewhat similar to what Sarah has seen as well. And she'd had subclinical MAS before, yeah, Regina, in the beginning, the first year and a half, yeah.
Yeah, I could just give a little timeline for
Yeah.
those who don't know the story. We're based in Long Island, New York. We're followed by Cohen Children's Medical Center. She was diagnosed in 2017. She never had arthritis upon her diagnosis, but she was in a state of smoldering MAS with very high labs, high ferritin for almost a year. And then in October 2018, we started noticing like redness and, plumping of her fingertips, and which later was, discovered to be clubbing. We were seen by a cardiologist at that time. We did chest x-rays. We ruled out pulmonary hypertension. The x-rays showed some discrepancies, so we were pushing for a CT scan. But all the while, all of her inflammation markers and labs were continuing to become more and more elevated. So in December of 2019 is when 2018, I'm sorry, is when things started to really ramp up, and arthritis presented in her left knee for the first time after a year and a half post-diagnosis. We had a knee injection, a steroid knee injection, which seemed to resolve that issue pretty well. But she had hours of morning stiffness, like the disease was definitely progressing. We added cyclosporin to her regimen. By May of 2019, we went in for the CT, which confirmed ILD. All along, we're planning to attend the SJIA conference at the end of June. So we had booked our flights and we're trucking along, getting our second opinion with Cincinnati. And then all of a sudden in the beginning of June, her inflammatory markers just started climbing, and we were making arrangements for her to go in for solumedrol infusions. And then within a week, all of her markers just went off the charts. So much like Sarah, Juliana went into fulminant MAS very, very quickly. Just before her third birthday, she was not responsive to traditional therapies. She was on 4 shots of anakinra daily. Cyclosporin IV, cyclosporin, prednisone, solumedrol. It was a roller coaster up and down. And then on her third birthday, we started that morning in the hospital with a chest x-ray, and she had no fluid in her lungs on June 26, 2019. Later that evening, we were starting to notice her having labored breathing. We started to do chest physiotherapy. By that evening, she had fluid in her lungs. Her SAT rates were at 77. We moved to PICU. All along, I had reached out to the foundation, and they told me about the clinical trial. And I was begging with the rheumatologist there. Many didn't even know about the drug, other than its use for HLH. And it was just not an option. I mean, I was 29 weeks pregnant with my son. I did not want to get on a plane and go live somewhere else for 5 weeks. But at that point, she was going to die. I can say that now, but she was dying in front of me. So we were medevaced to Cincinnati Children's Hospital on June 28th. At a glance, I was just looking when we arrived, her ferritin was 35,000. By the next morning, June 29th, when she received her first dose of Gamifant, her ferritin had risen to 75,000 overnight. Within hours of her receiving her first infusion of imipalumab, she sat up, she asked for food, she was chatty, she was hungry, she was a 3-year-old, and it was amazing. So I'll be the first person to say that a clinical trial saved my child's life. It was one of the better experiences we've ever done. So she had 8 infusions before she met the clinical trial criteria to be in MAS remission. I'll just say that her labs were still a little wonky upon discharge, but she met the clinical trial she met the criteria for MAS remission. At that point, we were discharged. She left the hospital. We left Cincinnati in July of 2019 on 100 milligrams of anakinra and prednisone, which we were tapering very well post imipalumab, lower than she had ever been able to get to. So I was very optimistic. What I'll say is that we continued the long-term trial, and I can speak more about the follow-up study, which had us going back and forth from Cincinnati to New York over the last year and the last leg of the journey during COVID. But once my daughter of October 2019, we started really coming down on the prednisone. She, again, needed more and more Kineret. And by December, we were on 300 milligrams, 3 shots a day for a 4-year-old, which was really challenging. And quality of life, is something to think about with these little kids. So back to Cincinnati in February of 2020, just before COVID really kind of got really big. We decided to make the change to Actemra to an IL-6 to give it a shot, because clearly she was needing so much of the IL-1s that, her body was so little. We didn't want to try Alaris yet. She started with the ACT pen, and we were on the ACT pen from February 2020 until August 2020. And again, she was not able to come off prednisone. You will see like major cushingoid appearance. And again, in July of 2020, her rash started to appear again on her legs. So after several months of being on tocilizumab, she was starting to fail that. We then went back to Cincinnati. At that time, we decided to try tocilizumab infusions. So she started toci infusions August 31st of 2020. And within 5 infusions, she had an anaphylactic response. So it was really interesting that after months of being on that drug, but in an injection form, she now had a full anaphylactic response. We were in an infusion suite. She was pre-medded. Within a few minutes, like her body turned full red and she started to have like breathing issues. We were able to resolve that. The next step of our journey is kind of interesting because her last dose of the tocilizumab was on October 12th. Between October 12th and November 30th, we were fighting insurance approvals for Alaris. So she actually had no biologic medicine in her system or whatever was waning out of the tocilizumab. She was being sustained only by Solu-Medrol infusions and prednisone. So she was on Alaris from November 2020 to April 2021. And again, we consulted with Cincinnati. Her labs were, increasing. She started to have this strange rash again, not an SJA rash, along her back, her shoulder blades, where she would scratch herself until she bled. And that for me was kind of a sign that her inflammation was out of control. And sure enough, we went back to Cincinnati and her IL-18 was just as high as, when we were failing anakinra. So my daughter always has seemed clinically well. So there's a little bit of a deception there of what's going on the inside and the outside. What I will say is we discontinued Alaris in April 2021, and she started tofacitinib, Xeljanz. She has had the most control to date on Xeljanz. We were able to come off all biologics since April 2021. And in October of 2021, she was able to fully come off prednisone for the first time since her diagnosis in 2017. She's now fully off prednisone and only on tofacitinib. She's on pulse Solu-Medrol. We were on a bi-weekly. Now we're spacing it out to every 3 weeks and every 4 weeks, and cyclosporin. So right now she's very well controlled. She's thriving in kindergarten, which I didn't think would be possible. I really think emapalumab was a reset for us. After coming off all of these drugs, she's grown 3 inches in the last year. So I'm cautiously optimistic.
That's great to hear. But your story really shows the interweaving of the SGIA and the MAS. So I'm going to ask you the same question I asked Sarah. Suppose for the trial, you had to go off the biologic medications for the SGIA. How would you take that? What would that do to her?
In fact, the trial criteria at the time of the protocol did require or request that they would be all off other medication. But Juliana, she was very, very, very sick. So I believe they broke protocol and allowed her to stay on those medicines in the beginning to at least make sure that she was stable enough to receive the emapalumab. So I don't know. I mean, we were at such a critical juncture that it was do or die, and that is really the only reason why we jumped on a plane in the middle of the night, 800 miles away, and relocated for 5 weeks. I'll also say that we did break the trial follow-up protocol, again, because of the distance that I live. The schedule called for repeat visits. And again, I was having another child. So all of that had to play into effect, but I did see the value in the long-term study. This data is so important. This drug is so important. She was the first child in the United States. This is my second time at Next Gen. And at the last one, I was really happy to hear that the other parents after that conference, their children got that medicine. So, this is the forum to advocate. And I thank you for having me back.
Sure. So, talk to me a little bit about the repeat visits. I mean, you see the value in that. And I think Regina in our community is like the biggest advocate of clinical trials and really has played a crucial role in educating the entire community about clinical trials. But what kind of follow-up you were doing when you went back? Do you think that would have been possible at a local center where you went in and they took all the information and they sent the blood work to maybe Cincinnati? Do you think that there was the kind of things that were going up during the follow-up, could that have been done locally?
I had asked, I will say there is nothing like Cincinnati. The quality of care, the 360 care, the desire to get the children well all around, not just in the area of focus. So I had asked if, to be honest, from a parent's perspective, I'm flying 800 miles. And then during COVID, we drove. We didn't want to get on a plane. When you get there, we're getting weighed, your vitals, things you could get done anywhere. And really, it's having those experts, Dr. Grom, Dr. Schuler, everyone take a look at her, that is worth the drive. But the lab values, I have not been able to have IL-18 drawn at my center and sent to Cincinnati. I really want it, but it's kind of been hard for me to deal with my center in getting that information. Same thing, I feel it's valuable to go and have the CT done and looked at by the same team, even though she's followed with a pulmonologist here in New York, but it definitely has its challenges. And sometimes when you realize, I'm spending 16 to 18 hours round trip traveling for a 1 hour appointment, it is like that 1 hour of gold. I want to make sure that I get everything in. So when we're at Cincinnati, I make sure we've done CTs, 6-minute pulmonary function tests, abdominal ultrasounds. We even participated in another trial for lung ultrasounds. It's like, I want the experts to have access to her. Unfortunately, it's halfway across the country.
Got it. So you're taking the remote visits, the return visits, the chance to get the medical care that the kid needs, but for the purpose of the trial itself. Okay, understood. I think that's, I see a few questions in the chat. So sorry, I was, here, I'm seeing Scott's comments. So I think we are here with the patients as we move into the next session, where I think it's Alexei and Fabrizio. So I'm going to stop sharing my screen, and Alexei and Fabrizio, you guys can take over at this point.
All right. So for those who are not pediatric rheumatologists in this audience, I would like to briefly remind that the term macrophage activation syndrome was initially introduced by Dr. Griselli and Anne-Marie Prieur in 1993. In this particular paper, they described 7 systemic JIA patients who very acutely presented with a strange hyperinflammatory episode that looked like disseminated intravascular coagulation. And the bone marrow biopsy in those patients showed activated non-neoplastic macrophages exhibiting this hemophagocytic activity. They were destroying essentially normal blood marrow elements in all these patients. And that's how the term was initially introduced. So we still call this complication macrophage activation syndrome. And in the current literature, this term refers to an acute event that typically presents as a complication of a chronic rheumatic systemic inflammatory disease. It is caused by excessive activation and proliferation of T cells and well-differentiated non-neoplastic macrophages. These macrophages exhibit hemophagocytic activity, and this massive systemic inflammatory response is typically associated with cytopenias, liver dysfunction, coagulopathy consistent with disseminated intravascular coagulation, and extreme hyperferritinemia. It's certainly most common in systemic juvenile idiopathic arthritis, And unfortunately, it is a life-threatening complication of rheumatic diseases, and the mortality rates still reach 10–20% even in the best centers around the world. Now, very briefly, I would like to sort of summarize one more time all these challenges that we have to deal when we run clinical trials in macrophage activation syndrome. So I will start with a few general comments. So the first one is that so far, all the eligible patients in the ongoing trials with those who failed high-dose corticosteroid treatment. And one issue that we still need to resolve is the exact definition of corticosteroid resistance. And I'm specifically referring to the maximal doses and duration, or minimal doses and duration, to qualify those patients as a corticosteroid failure. And unfortunately, the definition of corticosteroid resistance certainly differs between different centers. That may complicate the enrollment of the patients. And that's something that we, as a group, we need to clarify. The second issue, as you just heard from the parents, stopping the background medications would be very challenging. Again, MAS is an acute event occurring in the context of a chronic inflammatory disease that needs to be controlled. And if the underlying disease is not controlled, controlling MAS will be much more challenging. And the other issue is that most of the eligible patients so far have been very sick, and in fact they were enrolled at the time when they were in the ICU setting. And not that many pediatric rheumatology centers, at least in the US, are capable of handling a clinical trial in the ICU setting. Those patients are very sick. Those patients require very careful monitoring and clinical data collection 7 days a week, 24 hours per day. And again, not many centers are equipped to perform that properly. So for that reason, most of these patients are transferred to larger centers, and that's exactly what happened in the previous trials. After the discharge and return home, those patients are supposed to come back for follow-up visits. And that may be very challenging, particularly to us. It happened during the COVID epidemics. So certainly that led to quite a few protocol deviations. And again, sort of the question that we would like to address here is, could we use clinical exam findings from local physicians for those long-term follow-up visits? That would certainly simplify the life for our patients in a very dramatic way. The other thing I would like to bring up now is that sort of in general, those traditional clinical trial designs that we used in systemic juvenile idiopathic arthritis have been rather challenging. Again, most of the patients meeting the trial inclusion criteria are in the ICU setting. Given the life-threatening nature of the disease, a placebo arm is not ethical. And since it is an acute event, a withdrawal design is also not appropriate. So what could be an alternative to this sort of traditional trial designs? And the question is, can we use historical cohorts, natural history studies as comparison groups? If we choose this route, it's important to make sure that the historical controls will include the same type of patients as we enroll in the trial. So we need to look at the inclusion criteria and make sure that, again, the historic controls match our trial population. As an example, the existing trials require failure to respond to high-dose steroids. Again, in those historical studies, we certainly need to focus on this specific population. What kind of data needs to be collected in those registries, retrospective chart reviews? Again, when we assess the response in clinical trial, we look at the time to complete overall response. We look at at this in a more granular manner. We look at time to ferritin normalization, time to liver enzyme normalization, time to platelets normalization. We also need to look at the overall death rate, and more importantly, I think we need to look at the cumulative exposure to the drugs that we typically use to treat macrophage activation syndrome. Many of them are very toxic. We certainly need to look at the ability to taper corticosteroids and calculate the total exposure to corticosteroids required to treat an episode of MAS. We need to look at the number of patients that required the addition of etoposide and the total number of infusions, as well as total exposure to other immunosuppressive drugs that were used to treat macrophage activation syndrome. And I think if we have two matched populations, clinical trial, historical cohort that has very similar clinical characteristics, and if we look at these parameters, I think we should be able to assess the efficacy of the treatment. And again, that's a sort of the question that we have to the FDA, whether this approach would be acceptable. Now, very briefly, I would like to mention some other specific challenges for trials in specific different MAS patterns. So if you sort of think about patterns of macrophage activation syndrome, we distinguish the classic MAS that occurs sometimes during the course of the disease. We see it in approximately 70% of patients. But in about 25% of MAS events, MAS occurs at disease onset, and that may be challenging. And then we have this sort of very peculiar group of patients that have relapsing or smoldering MAS. They never develop or only occasionally develop full-blown MAS, but sort of on a continuous basis, they have some features of MAS. And there are specific challenges for each of these patterns. So if you look at the patients with classic MAS, again, the major issue here is how to handle the background therapy that is absolutely necessary to control the underlying disease. In addition, when patients develop MAS, we typically start adding new immunosuppressive medications. So there will be some medications initiated just to the enrollment in the clinical trial. So the major challenge here will be how to distinguish the effect of the experimental drug versus the background therapy. And again, that's something that we need to discuss. Now, if we look at the patients who develop MAS at the initial presentation, the challenge here is that the sort of the massive hyperinflammatory response that we see in MAS will completely mask the underlying disease. And it's particularly challenging in conditions like Kawasaki, lupus, and certainly systemic juvenile idiopathic arthritis. And as you just heard the stories from the parents, many of these patients, in fact, are diagnosed as HLH, and they start the treatment with very toxic medications, including etoposide. So the question is, and that, again, I would like to hear the FDA perspective on that. Would it be appropriate to enroll patients like this in a clinical trial for MAS without the definitive diagnosis of the underlying disease, and then define this disease later? Because when we taper medications, when we taper steroids, the underlying disease does show up, and at that stage, we can clearly define the diagnosis. I would like to stress the point that this patient population is very valuable for the clinical trials because the MAS here occurs at disease onset. These patients do not have any kind of background immunosuppressive medication. So really, that's a population where it's probably the best way to assess the effect of the experimental drug. So it would be a pity if we lose this patient population in clinical trials. And finally, my final slide is, so there are certainly specific challenges in patients with relapsing MAS. Again, these patients typically have laboratory features of subclinical MAS, but do not meet full criteria for MAS. So again, the inclusion criteria may be a bit difficult to define in this population. This patient include that group with predominantly liver disease, which and I think in that patient population, we could make a huge difference. But it's a relatively rare phenotype for a separate clinical trial. And again, we would like to discuss the option of including them as a subgroup in some type of other basket clinical trials. And these are just a couple of slides from Rashmi about the stories that we just heard. Rashmi, would you like
Yeah,
to?
Alexei, you can skip these because we just went over that. That was I was sending the FDA ahead of time.
So anyway, that's my slides, and I hope that we now can have a discussion to address these issues.
Yeah, I believe Nikolay is there in the audience. I just had a quick chat with him. We can ask him to comment.
Yeah, I'm here, Rashmi.
Hi, sorry, sometimes, yeah.
Sure. Well, first, I want to say that all the patient stories were moving and certainly important for reminding us of the challenges with managing these patients. And this is not something that we're not aware of and we haven't thought about. We had extensive discussions with sponsors designing programs for these conditions. So, and we have thought about many of these issues, and I'll be happy to share kind of more high level comments that I have. So first, I just want to clarify, do you think that refractory SGA is different from the MAS? In other words, should these be approached in a different way with different considerations?
Correct. My personal opinion that although linked, these are two different pathogenic pathways, the underlying systemic JIA and MAS. And we may have different degrees of MAS severity in patients with systemic JIA, and that may look like a continuum, but in fact, pathogenically, I think those are two different conditions, two different phenomena, clinical phenomena.
Right, right.
So, and that's the reason when we defined refractory systemic juvenile idiopathic arthritis, we did feel that it was necessary to distinguish those four categories. There will be refractory SJIA by itself, and they will be some refractory patients where the MAS component is a major issue. Fabrizio, would you agree with that?
Yeah, I do agree with the fact that there are two different pathogenic pathways. Although there is a continuum, and obviously you can't draw a line, but there is autoinflammation, and then it becomes hyperinflammation. And you can have MAS in refractory SGIA, usually it's recurring MAS. Okay, one of the reasons a refractory SGIA is a refractory because it has several episodes of MAS. They may be severe or not severe. They may be responsive or unresponsive to standard of care with high-dose glucocorticoids. The MAS itself may be responsive to glucocorticoids or may be severe in any patient with SGIA, even in the standard SGIA patient with very good response to L1 or IL-6, there may be a severe MAS. Okay, and there are two distinctive pathways. And what we assume is that the drugs that treat SGIA are not effective in MAS. Now, again, it's a bit fuzzy, but it's, and yeah, I think we should keep it simple here and think of two different phenomena. One, certainly autoinflammation contributing to the other, hyperinflammation.
No, I think that's certainly helpful to provide context about how to think about these, because I think the stories that we heard included both patients with sort of refractory percolating, persistent SGIA, and other stories with sort of florid or fulminant MAS, which is kind of a lot more urgent situation that treatment decisions and designing of clinical trials certainly pose different challenges in these two settings.
And there is an issue that Nikolay, you finished the one other thing that I want to point out.
Okay, well, maybe if you want to go ahead.
No. I don't want to disturb your flow.
Oh no, well,
you asked the question and you had a flow.
Yeah, well, it's sort of an open discussion, and I'll just try to make it simple to explain what I think, at least. I'm not sure whether this is representative of what the rest of the group thinks, but so for SGA, we have several drugs approved, and we know we have good evidence that they work, not for all patients, but they do work. And for, unlike for MAS, where we don't really have pretty much any treatment approved at this point. So again, given that these are probably different pathogenic diseases with different level of urgency, different implications, I think the approach to demonstrating or generating the evidence of efficacy might be different. So I think Alexei presented a few slides with very challenging questions. And we've heard this multiple times of how to design clinical trials to demonstrate this efficacy of a new product. And I think I have to make it clear to the group that we need to have some sort of a control group to demonstrate or to know that the effect that we see is due to the drug and not to something else in the natural history. Given the complexity of this disease, it's not well, these two different diseases and sort of the overlapping features. So that's kind of a fundamental principle that we use to assess for efficacy, safety aside, just first to demonstrate efficacy. And again, as you know, the traditional trial design, which is a placebo-controlled design, is sort of the gold standard and the easiest to interpret. And by placebo, we don't really mean placebo. We mean patients are on their treatment as though they would be getting it in the standard of care in any hospital, any place, and then add on an investigational treatment, which at this point, we don't know whether it works or not. And this is really the question that we need to answer, or we need to have data to interpret to say that a drug works. So this is really the challenging part, that if a placebo-controlled trial is not an option from patient or investigator perspective, then the question is what kind of control can be used. So again, I think in the context of a more slowly progressive disease, even though refractory, the level of urgency might be different than in the case of MAS, where you can have a deterioration in 24 hours. So what the control should be in these two different settings might be different. But I think what I want to make clear to patients and maybe ask for sort of their take on this is, and I saw a comment in the chat that the parent was reassured that this trial would not include placebo. And my question is, do you feel more comfortable not knowing if the drug might work at all or not? That's my question. If there was a placebo arm or not. So in other words, should we assume that the drug works? We certainly, this is kind of the premise of designing a clinical trial, but should we assume that the drug works, that there's no other way that we would enroll a patient otherwise?
May I answer that question partly, and
Sure.
I'll let other parents speak up.
Sure.
So in the last year, after our last conference, several patients who would not have qualified for trials and who had more of the again repeat MAS have actually started imapalumab, and insurance has actually, we've been able to get it covered through insurance. And so now in our group, we have about 5 or 6 patients who have actually received imapalumab outside of the trial context. And for several of them, you'll actually hear from several of them in the next session where we have the refractory SJIA, because these diseases are so interlinked, it's complex. And we have seen, a resolution, not a full resolution, but really much better control of the MAS aspect, while the SJIA aspect keeps on going up. So, I mean, the answer in a long way, I'm answering your question is that, do the parents think that it works? So from, several parents actually, after hearing about Regina's story, etc., took it, made it their business to go and ask their doctors, is there any way what can we do to get this for my child? So I think people are talking about in the group. I think Zuli, you are here. I think there's several patients who've received, Sarah has received, Melissa, Yeah, so I think.
Yeah, I think this can only complicate conducting a clinical trial if the drug is available outside of the clinical trial setting, and I think that makes it even more challenging for us to collect the information that we need to conclude that the drug should be approved. I think that's a point of consideration, but
I completely agree with you. I completely agree with you, and I wish that we had a forum to share this information more regularly. But I completely agree with you. But if a patient is deteriorating, and we in the group we do this, we keep on telling patients participate in the trials. But then if the patient is deteriorating, you have to do the best to save that patient. So there's a dilemma here. And we worry that the same thing will happen that happened with anakinra, where it's never been approved. So everybody fights insurance on their own.
So with the need of the patients being and the families being so high, would an N of 1 design be helpful? Meaning that each patient is their own control, that would have the advantage to address this large interpatient variability of severity and disease courses. Every patient seems to be internally consistent with their course. So if you could show, maybe a week before how the disease was going, then you start the medication and you would then have response. Would that be something that's acceptable to the FDA, or, might be an option?
So I would probably refocus the discussion on the considerations for a control group. And again, given that placebo might not be palatable to patients and the parents and the investigators, the question is what other control, group options might be. And I think this might be a part of the next session discussion on external controls and historical controls. But I noticed that there are several comments that some of these patients might not have been alive if it was not for this medication. So if the mortality is an endpoint that is well characterized with the standard of care for similar patients, that could be, that's a hard endpoint, certainly a meaningful and significant one to be used as part of the external control to show that if you treat these patients, they just go on with their life much better than they were, with the standard of care. Again, I think this might be a point for the next group discussion. I cannot really comment on the N of 1 proposal. Generally, we don't use pre and post treatment approach to assess efficacy of drugs, but I don't want to exclude any of these considerations. We certainly want to make sure that we have confidence in the data that the drug works to make it available to all the patients, not to struggle with the coverage, insurance, and whatnot.
Okay, so I wanted to make a comment on something that Alexei said, and you also, Nikolay, mentioned it during your thoughts, which are very helpful. N of 1 is something we can make advantage of because most of the patients go up and then go down, and you can see this in some of the patients. One thing I like to elaborate a little bit is the background biologics, because on the one hand, the MAS at onset are biologically clean, most of them, but in some of them, you're not 100% sure is SGIA. SGIA will become evident later when you taper the treatment, the glucocorticoids, arthritis will appear. And therefore, this is a patient that is evaluable, I think, even if maybe was not 100% sure they have SGIA. The CARA operational definition of a new case is very helpful in these cases, and it was obtained through consensus. The other thing is the background biologics, which really concern me a little, because if we accept the concept that the SGIA and MAS are two pathogenically distinct diseases, if MAS presented and worsened significantly and did not respond to high-dose glucocorticoids during a background biologics, whatever that is, it's fair to assume that inhibiting that pathway was not effective in MAS. So I'm a little concerned, and there is obviously a concern in tapering biologics, which Hermine brought up in the chat. which I think it's very important to understand pathogenically why it is concerning. And I wouldn't do it. And not even if Alexei was, sitting in the room beside mine, because the background autoinflammation is one of the contributors to MAS. You have an unstable patient, you withdraw your background therapy for autoinflammation of SGIA, and you take the risk of exacerbating one of the contributing factors, and your patient will be even more unstable. So putting these two things together, really, I think that, present and future trials on MAS should not be concerned by, and us evaluating the trial and the efficacy of the drug, should not have a concern of the background biologics. Because otherwise we make things really too complicated for the patient, ethically and practically. Your patient parents may refuse to be recruited in the trials, and I would agree with them because of the danger. And on the other hand, we make things very complicated on a feasibility issue because, biologically clean patients are just not there in 2022, not in 2019. So I want to make these comments, and maybe I was too strong, Nikolay. So.
No. I think you were spot on, and I actually completely agree with you that this would not be our expectation or requirement that background standard of care is altered in any way. Actually, this may introduce a lot more noise. Not to mention the risk of potentially maybe exacerbating sort of the underlying hyperinflammation. Right. So I don't think this has been a requirement from the FDA, at least, for patients to discontinue background treatments. And I would consider
on the evaluation side. I hate to interrupt you. It's on the evaluation side has been.
So I think if you introduce multiple interventions, at the start of the study, then it makes it more difficult to know whether the effect is due to the investigational treatment or anything else that was started. But I would consider sort of standard of care anything that patients have been on and required for their management as though they are not in the trial. Again, I cannot speak for the larger group, but our take has been that background standard of care should be given to all patients to ensure that they're managed at least with what is currently available. And then the investigational treatment is on top of that, and you're assessing the effect of this, the additional effect of this investigation. So again, if there's some discrepancy in the approach, I'm certainly interested to hear, and you can flag it, or investigate, or sponsors can flag these inconsistencies, or but I think this is kind of a basic premise. And to me, that raises also ethical questions about asking patients to wash out or stop background treatments. We don't think that they're completely ineffective, or in most of the cases, they may be doing something that still keeps these patients, where they are and not get worse.
Okay.
So I have several comments. So I think most of us are talking here about refractory patients, not the arthritis per se, but MAS, lung disease, just the hyperinflammatory state, number one. And most of, certainly the families that have been talking today, these are the severest of the severe, the outliers, the ones that need this kind of stuff. So I would say for the bulk of systemic JA patients, including those who have MAS at onset, they're going to respond to IL-1 blockade. So I'll push back on Alexei. I don't think those are patients that you're going to want to enroll in these types of trials. And I agree with
Randy, I think Alexei is right. Some of these patients do not respond to IL-1 blockade. The great majority of them do. The majority of them do, even at onset. They respond to IL-1 blockade. Some of them may not.
So if it's my child, and I know that 90% of them are going to respond to IL-1 blockade, why would I put them in a trial that is studying something novel? So that's my 2 cents. But so that's one.
No, but the sense here is another one. I'm sorry. The sense here is another one. Most of these patients are on IL-1 blockade, even at onset. Okay, and most of them do well. Yes, but
I'm talking about the patients that Alexei's describing, where you make the diagnosis at the same time that they're having MAS.
Yeah.
So anyway,
you can initiate IL-1 blockade anyway.
We can let that group go.
Yeah.
But for the trial, I agree with Nikolay that, you know, it's not like these therapies don't work at all. And sometimes all you have to do is actually increase the dose. I'm not saying that's going to work for many of the kids who are presented today, but I don't think you should take patients off. It is complicated, but if you design your trial correctly, that's not what you're asking or answering. So for example, I do think we have equipoise because we don't know the right answer. And I'll just give you two potential therapies, one being emapalumab, one being one of the JAK inhibitors like ruxolitinib. We don't know which is going to be better for these refractory patients. We just don't. And so you could have a trial where patients who are having refractory MAS or refractory bad systemic JIA, lung disease, however you want to design it, can enter the trial on the meds they're on so that they can stay alive at that point. And then you randomize them to one of those two therapies. And the beauty of most of these therapies and the disease is you need to know right away, like within a week or two. And if they don't do well, you can cross them over onto the other side. And so you have the control in that sense. It's not a placebo control, but you have knowing which of the therapies seems to help the group overall. So I don't think you have to necessarily use historical controls or N of 1 trials. I think we can be creative because we don't have the right answer. And so equipoise is out there.
How do you define it?
I just a caveat to this approach, Randy. I think if one of the products works, then we may have an answer. But if both work or if both don't work, then we may not have the answer at all. This is kind of a caveat.
With Nikolay.
I think the challenge with active control studies is that if we don't know the effect size of a treatment, it's very hard to use active controls, or in this case, you know, sequential or whatever controls. And just to put it out there for the discussion, I know we have raised this before, is one way to avoid placebo in clinical trials or placebo-controlled trials, whether these are prospective placebo controls or randomized withdrawal placebo, is to use active controls. For systemic JIA, there are two treatments at least approved in the United States for which we have a pretty good, or at least for one of them, we have a good sense of the treatment effect, which is fairly large, and one can come up with a study design that could be feasible to do an active controlled study. I know that this is probably more challenging and may require more patience, but that would certainly obviate the need for placebo. It will ensure that all patients will receive treatments. Again, I just want to put it out there for the sake of the discussion and to raise this as an option for studying new treatments where we already have some approved therapies.
Okay, I think I thank everyone